So I'd like to take this time to introduce Dr. Ted Findlay. Ted has been a doctor for 25 years in a community-based family practice, and he also has current clinical commitments at the Calgary Chronic Pain Center, where he has been a pain management physician for over 20 years. He's also an academic teacher, I suppose, and has an appointment at the University of Calgary and has participated in a number of regional, provincial, and national organizations and initiatives related to chronic pain and MSK Health. He is a member of the ACFP Mentoring Network, so he is one of our mentors, and we appreciate his mentorship and his leadership all the time. And he also was really generous to join our hub team. So, but we're very excited for him to give a presentation on fibromyalgia today. So it's one of the most exciting topics. I think it's always one of our highest rated topics whenever we ask for topics of interest. So I will let Ted take it away. And Ted, just let me know when you'd like me to advance the slides, and I'll do that for you.
Yeah, thanks very much, Leah, for that introduction. And I guess we can take the next slide, please. So I don't have any significant disclosures. Many of you will have known me from prior ECHO sessions as a hub team member. Next slide, please. So this is an outline of what I'm hoping to cover on the topic of fibromyalgia syndrome in the brief 10 minutes that's available to us today. Obviously, any of these topics could be explored in more depth, and there'll be some time for questions at the end. And I've also forwarded 3 articles in particular that should show up as references later in the slides. Next slide, please. So to begin, I still hear patients tell me that their doctors told them that there is no such thing as fibromyalgia. And in fact, technically, that actually may be correct, because the proper term is fibromyalgia syndrome, and that word at the end makes all the difference. So fibromyalgia syndrome is not the definition of a pathophysiologic process in the same way that we think of diabetes or hypertension, but a syndrome describes a patient population without necessarily defining the physiology that leads to that expression of symptoms, and in this case, widespread pain. So fibromyalgia syndrome, and I'll sometimes talk about it as FMS, just to be brief, may be a common symptomatic expression of 1 or 4 or 40 different pathophysiological processes that have a common symptom expression. We simply don't know. However, by defining a specific set of criteria to capture that population, it allows us to study that population to see what there is that we can do to be of help. Next slide, please. So one of the references is the 2022 UK Clinical Guidelines for Fibromyalgia Syndrome Diagnosis. And this is the contemporary definition of FMS, a condition characterized by persistent and widespread pain associated with intrusive fatigue, sleep disturbance, impaired cognitive function, and physical function, and psychological distress. It had previously been referred to as fibrositis or fibromyositis, but these terms are not used as they imply an inflammatory activity, whereas we know that the predominant mechanism is in fact changes in pain processing that occur within the central nervous system. Next slide, please. The UK guidelines also emphasize the importance of categorizing patients as best as possible as having a nociceptive, neuropathic, or nociplastic pain process prior to selecting treatments and tailoring treatments to that type of pain. And this is actually excellent general advice for any pain condition, and I would say supersedes the older paradigm of the World Health Organization pain ladder, which many of us learned, but I would say that those concepts are rather outdated. And fibromyalgia falls within that nociplastic pain category. Next slide, please. The UK guidelines also talk about the importance of excluding conditions that may present similarly, including drug side effects, such as we might see with statins, certain physiological processes, such as thyroid, hypothyroid disorder, or anemia, and of course, mental health. It is noted, however, that fibromyalgia syndrome is not a disease of exclusion, and can present coexistent with other painful or non-painful conditions that can affect its presentation, such as, for example, sleep apnea. Next slide, please. The UK guidelines refer to the American College of Rheumatology diagnostic criteria from 2016, which introduced the concepts of widespread pain index and symptom severity scale and the relevant cutoff points to establish the diagnosis. The WPI provides a score out of 19, the SSS a score out of 12, and they can be combined as noted. The numbers are on the slide there. They talk about having symptoms in at least 4 or 5 body regions for at least 3 months. Next slide, please. A one-page worksheet is included in the UK guidelines and is reproduced here. It's a little bit hard to see, obviously, on putting it all on one screen, but they highlight the presence of fatigue, brain fog, sleep disruption is commonly found alongside the pain complaints, as well as irritable bowel, mood disorders, and headache. And from the body map, pain is looked for in at least 4 of the 5 noted body regions. Next slide, please. However, if you're a busy family physician, the idea of yet another form to complete might seem a bit impractical, especially if it's not going to lead to any real change in your treatment plan. And so for you, I offer perhaps a simpler practical definition that has served me well, and that is pain that affects both the left and right side of the body, above and below the waist, with probable axial involvement at some level, frequently seen in combination with sleep cycle abnormalities and GI symptoms, memory and mood comorbidities for more than 3 months, and in the absence of a rheumatological or inflammatory diagnosis. Next slide, please. The most recent Canadian Fibromyalgia Syndrome guidelines were published in 2012 and haven't actually been updated. And this 2012 guidelines obviously precede the American College of Rheumatology 2016 definition and the introduction of the WPI and SSS scales. It's important to note that the 2016 guidelines and the 2022 UK guidelines do not, in fact, require any physical examination or presence of actual tenderness to make the diagnosis. It's entirely symptomatically based. However, I find it unusual to have a fibromyalgia syndrome patient who does not have actual tenderness to touch. And if I do find that they don't have tenderness to touch, I'm beginning to think about some other process. And the 2012 Canadian guidelines provide some guidance on what to look for. These guidelines note that the 1990 American College of Rheumatology tender point count, you may recall this if you've been around for a while, they talk about 18 characteristic sites and having tenderness at 11 or more of them. Those are no longer applied. But in practice, I can't really think of anything else that causes tenderness at the medial fat pads of the knees, the lateral epicondyles, and the second ribs anteriorly. And so I particularly look for those as a characteristic when I'm doing a physical examination. Next slide, please. I'm sometimes asked if fibromyalgia syndrome isn't just widespread myofascial pain, and some clinicians think it might be. However, myofascial pain is much more regional than widespread, has characteristic pain radiation patterns with trigger point stimulation, and is not typically associated with the other fibromyalgia symptom complex, such as irritable bowel, brain fog, and non-restorative sleep cycles. Next slide, please. Can there be other comorbid diagnoses? Well, the 2022 UK guidelines reinforce that fibromyalgia syndrome is a diagnosis of inclusion that's reached upon positively confirming the diagnostic criteria and not by exclusion. And as such, it can certainly coexist with other comorbidities. And if it is recognized as being coexistent with other comorbidities, such as rheumatological conditions, then it can open up additional therapeutic options for treatment. Next slide, please. Moving on to the therapeutic options, the mainstays of fibromyalgia syndrome management have always been to correct sleep cycle abnormalities and to advance activity levels as tolerated. I make a point of telling patients that most will not find medications have a major role in helping them with their objectives, but some patients, if they're lucky, do find medications helpful, and we'll discuss those options in a moment. I've not seen a good reference for the effects of nicotine discontinuation or quitting smoking on fibromyalgia symptoms. However, many clinicians do find it important, and I know of some FMS programs that specify patients must quit smoking before enrolling into the program. And based on our understanding of the effects of nicotine on the nicotinic receptors in the autonomic nervous system and release of catecholamines, that makes sense from a physiological perspective. As noted by the UK guidelines, the identification and management of mental health comorbidities is also critical to success. Next slide, please. Pharmacologically, it's a short list of agents that have a demonstrable impact on fibromyalgia syndrome symptoms. The mainstays are the SNRI class antidepressants and gabapentinoids, and duloxetine, as well as pregabalin, have marketing indications in Canada for the treatment of fibromyalgia syndrome. However, it's, in my opinion, likely to be a class effect, and at some the other SNRI alternatives, and particularly the Milnacipran that's available in the USA, has obtained a marketing indication for the treatment of FMS in the USA. Mirtazapine in particular is commonly used to help with sleep cycle correction associated with fibromyalgia syndrome, although weight gain is a notable side effect. And interestingly, the medication works best for that purpose at lowest doses, 7.5 or 15 milligrams, and paradoxically not at higher doses. We routinely start magnesium in our FMS patients, as well as our myofascial pain patients, although I've not seen great literature on the subject. The citrate form is well absorbed and widely and cheaply available. And topical agents are often a great option for means typical of fibromyalgia syndrome. So whatever hurts that day, you can treat it with a topical agent. Next slide, please. What about opioids? Well, it was more common a few years ago, and still occasionally, to see patients being initiated on opioids for fibromyalgia syndrome, and when there's actually no real evidence for effectiveness for this condition. And in fact, the 2016 Drug Safety Bulletin of the Institute for Safe Medication Practices Canada, I find is an excellent patient that opioids are not indicated for fibromyalgia syndrome, or for that matter, for chronic back pain or headache. And there's been no more recent evidence that would change this recommendation. Next slide, please. So how do I approach this patient? So this is an actual patient-completed pain diagram from a recent consultation that I did at the Chronic Pain Center in Calgary. And at first glance, this looks like a pretty intimidating history, and you're going to need to spend 3 hours to figure out what's going on with every part of the body that hurts. For your shoulder, how long have you had pain? What makes it better? What makes it worse? What about your hips? How long have you had this pain? And so on and so on. But in fact, this can actually be one of the easiest patients from whom to take a pain history. And it goes like this. Is it fair to say that what you're experiencing is widespread pain that could affect you essentially anywhere on your body, varies from day to day in severity and location depending on what you're doing? So that's a 20-second history for fibromyalgia syndrome. And if it's positive, it's almost certainly fibromyalgia syndrome. And then I try and capture as much of the patient's pain experience as possible within those parameters. So they'll typically say, oh yeah, but I've been really worried the last couple of weeks about my shoulder. Okay, so you've had bad pain in your shoulder for the last 2 weeks. What was it before that? Well, before that, it was my hip. And how long did that bother you? Well, it was bad for about 3 weeks, but now I'm really worried about my shoulder, and so on and so forth. So you try and capture as much as you can within that widespread migratory pain paradigm, and then apply your usual question to that paradigm. So how long have you had this widespread pain, and what do you associate with the onset of causing that? What makes it worse? And I include stress, mood, and sleep. Well, what makes it better that the patient can do? And then I try and also important to set aside time for specific coexistent pain complaints that are the persistent ones. So they've got widespread pain, but besides their widespread pain, they have a headache disorder. Besides their widespread pain, they have very persistent pain in the low back that needs to be explored separately. Next slide, please. So what's new in fibromyalgia syndrome? One of the references is Year in Review 2022, and highlights from this should probably not be a huge surprise to this audience. Association with adverse childhood events and multiple traumas, PTSD, neuroinflammatory theories, as we alluded to earlier, It is seen with higher prevalence in those who have obesity and glucose intolerance. Small fiber neuropathy is commonly seen. And there's conflicting results, but interest in trials with ketamine, low-dose naltrexone, and cannabis, and also our TMS. Next slide, please. What about Alberta resources? Well, we're fortunate in Alberta to have some fairly widely available education and patient support resources for our fibromyalgia patients. And some of these are listed here, depending on the community that you're in. Alberta Healthy Living Program has an assortment of psychoeducational and cognitive behavioral therapy-based groups that may be of interest. There are expanding options within the primary care networks. Exercise and activity-based recommendations can be accessed directly by patients through Alberta Healthy Living at low cost or through the Alberta Health Services Rehab Advice Line. The Chronic Pain Center in Calgary does have the Fibro-Focus option that's run by Dr. John Pereira, who was one of the authors of the 2012 Canadian guidelines that we saw earlier. Next slide, please. This slide provides some information about the Fibro-Focus parameters, and further information can be found on the Fibro-Focus website, including referral instructions. Next slide, please. Finally, and once again from the 2022 UK guidelines, is a patient information handout that reinforces what patients are likely to notice with the condition, how it's diagnosed and managed. So that is the final slide that I had, and I think I see that the references have come up for you, and we'll leave that up while we take any questions.
Thanks, Ted. That was awesome. So interesting. I guess I'll just open it up to the floor for questions. Please just raise your hand and we'll get to you if anybody has a question.
So Adele did put a question in in the chat. I don't know if he wants to speak to it. I had the exact same question. Can you speak about mag citrate? And I've never heard of it either.
I was totally going to ask that question as well.
There you go. Yeah, so I have heard, and again, I haven't seen great reference, that it actually works as a kind of a mild NMDA receptor agonist, but we know that magnesium is used for things like headache and headache prophylaxis, migraine. It's used for treatment of preeclampsia, or at least it was, I think it still is. So it's an interesting, certainly an interesting treatment. Again, I haven't seen a lot of literature with respect to its use in widespread pain, but it's something that clinically we found can sometimes make a huge difference. Simple, cheap. You know, you can buy a big bottle of 150 milligram capsules at whatever pharmacy or grocery store or big box store that you like to go to and try it out. The only real thing to watch out for is, as a possible complication or side effect, is loose stools.
I was going to say it's quite often used as a laxative in like old-fashioned days, right? So, I was wondering too, Ted, what do you think the prevalency of fibromyalgia is? Like it's been such a strange diagnosis over time that that sometimes it's I think it's overdiagnosed and sometimes maybe underdiagnosed, given kind of the specificity of the diagnosis has changed.
Yeah. So the UK guidelines can, if you look in that article, they can give you some more specific details in terms of percentages and at what age range. It's more common in females, but at what age range and so on. The initial American College of Rheumatology guidelines in 2009, the one that had the count of tender points out of 18, I guess it was, were considered to be quite specific, but not very sensitive for the diagnosis of fibromyalgia syndrome, which is what kind of led to the changes subsequently in the 2016 ACR guidelines, where they basically did away with the physical examination and they said, if it hurts everywhere, and then it's probably fibromyalgia syndrome in the absence of an inflammatory condition. So that kind of turns that whole paradigm upside down. So now you've got extreme sensitivity without necessarily great specificity. So the truth may be somewhere in between. I think the idea is trying to capture a large number of people who may have fibromyalgia syndrome as a part of their symptom complex so that you can offer them treatment options.
Anyone else out there have a question? Oh, Lori, go ahead, please.
Can I throw out a weird question? Because I have been wanting for a while to try some of the like lemborexant, the orexin receptor antagonists, to try to work with the sleep issues with people with fibromyalgia. And I'm having coverage challenges, but I'm wondering if you've had a chance to play with that at all and what you think of the possibilities.
Yeah, that's an interesting question. I would say that it is an interesting option that, theoretically might be of value, but I've not actually seen any great studies.
Yeah, well, definitely not in fibromyalgia. Sam and I kind of did a search of data. So Sam is one of our pharmacists at the Chronic Pain Center, looking at the data around the adverse effects with that class of medications when you're using them for sleep, and they look great on paper. So Sam did an education sheet for patients that we have that we can give out to patients when we use it, but I'm having coverage challenges. So Julie, do you know anything about that?
No, the coverage issue is going to be a thing for a while since it's so new as well. I've actually had one patient been on it. Finance was not an issue, so he kind of paid out of pocket and tried it. Although it's really well tolerated compared to Zolpidem and Zolpidem and so on, he actually had a pretty bad paralysis after the first dose, which is one of the rare side effects, and it was just absolute scare for him. So he shied away from that one. The lemborexant actual study that came out from the drug company and so on, that had a lot of excluding criteria. And I can't remember the details right now, but I remember just me, Alice, and Sam, like just pharmacy team, just reading through that study. And they excluded a lot of patients that we would see. I just can't remember the details, which was a little bit sad, but also it's still well tolerated compared to others in general.
Fair enough. It's challenging with fibromyalgia. There's not a lot of medication options. And one of the things that they really struggle with is sleep. So
that's great. I just want to say also that any of Ted's resources we will put in our library, so we'll have them available for anyone who has that link again. So and again, if you've missed it, you can just let us know, and we'll definitely send that on your way. Adele, did you have a question? We want to get to your case presentation right away. So
yeah, sure. Do you also find chronic pelvic pain also part of the constellation of symptoms that some of the fibromyalgia syndrome patients encounter? And how do you kind of fit that into everything else, given that I guess there's a number of different, resources, services that focus more on that?
Yeah, so again, this could be an example of something that could be comorbid or coexistent. So fibromyalgia syndrome patients typically have pain that could be anywhere, but it's not usually everywhere every day. So if they have something that is persistent, localized every day, then it's likely to be something different. So if they have pelvic pain as part of their fibromyalgia syndrome, then it'll come and go. Whereas if it's a primary pelvic pain floor disorder, then it'll be more persistent.
okay, I guess we'll get started then with our case presentation. Thank you so much, Ted. That was a great presentation, and as always, it's so interesting, and these kind of things just are we're learning so much more all the time. So it's great to have an update.